Imagine a major highway, suddenly block traffic, just grinds to a halt. And fast action is absolutely crucial.
Yeah.
That's kind of what happens inside your body when a blood vessel gets clogged.
Exactly. And for centuries, the only real emergency fix was, well, invasive surgery.
Right, cutting things open.
But then came a real game changer, the ability to actually dissolve those blockages from, like, the inside.
Okay, so today on this deep dive, we're digging into the fascinating science behind these revolutionary drugs and techniques.
We are, and we've got a really rich set of information to unpack, all coming straight from Rutherford's Vascular Surgery and Endovascular Therapy, the 10th edition.
Great resource.
Yeah, and our focus today is specifically on thrombolytic agents, you could call them, the medical plumbers that break down those clots.
Okay, so thrombolytic agents, just in simple terms, what are they actually designed to do?
Think of them as specialized demolition crews for blood clots in your arteries, in your veins. Their main mission is just to dissolve these obstructions, get the blood flowing freely again, and, prevent serious damage to organs and limbs.
Now, it sounds like the field has evolved quite a bit. I saw some older drug names mentioned in the chapter.
Mm.
Beyond just being newer, what were the key advancements? Like, what made drugs like Alteplase such a big leap forward compared to, say, Streptokinase or Urokinase? For you as a clinician, what was the difference?
That's a great question. So while the older drugs, they could certainly dissolve clots.
They worked?
They worked, but the newer generation, like Alteplase, you might know it as RTPA, they tend to be more targeted.
Oh, okay.
And that means a lower risk of causing widespread bleeding throughout the body.
Right, systemic bleeding.
Exactly. And they're also generally more effective at restoring blood flow quickly, which is critical in these emergencies.
So those older ones, Streptokinase SK and Urokinase UK, they're just not used much in the U.S. now.
Much, much less common. Still around technically, but newer options are preferred.
Got it. And these newer agents, what kind of emergencies can they actually tackle? What are their main targets?
Well, the FDA has given the green light for thrombolytics in a whole range of serious conditions.
Okay.
So that includes acute myocardial infarction, what most people know as a heart attack.
Right.
Pulmonary embolism, PE, that's where dangerous clots lodge in the lung arteries.
Scary stuff.
Very. Acute ischemic stroke, AIS, disrupting blood flow to the brain.
Critical.
Absolutely. And we also use them for arterial thrombosis and embolization clots in the arms and legs, deep venous thrombosis, DVT, and even to clear stubborn blockages in central venous catheters, the lines used to deliver medication.
Wow, quite a list. It sounds like a modern medical marvel. But this tech didn't just appear overnight, right? There's a backstory.
Oh, absolutely. There's a history. The journey to understanding and using these agents, it actually began with some, pretty astute observations way back.
Like when?
In 1769, Morgagni. And later, Morawitz in 1906, they noticed something intriguing.
What was that?
That blood, after someone passed away, could either stay clotted or sometimes it would liquefy on its own.
Interesting.
Right. So this sparked the initial idea that the body might have its own natural way of breaking down clots, a fibrin-degrading agent, as they called it.
So they were seeing the body's own mechanisms at work, basically.
Precisely. Then, fast forward to the mid-20th century, and we had some really pivotal discoveries.
Okay.
In 1941, Millstone identified something he called lytic factor. We now know that's plasminogen.
Plasminogen.
Think of it as the inactive precursor, the thing that becomes the clot buster.
Got it.
Shortly after, in the 1940s, Kaplan and Christensen, independently, they zeroed in on plasmin as the actual fibrin-degrading agent.
So plasmin is the active form.
That's the active molecule that breaks down the clot's structure, the fibrin. And then finally, Albrechtsen isolated tissue plasminogen activator, TPA, in 1957.
TPA, that sounds familiar.
Yep, it's key. And it all ties back to our normal blood clotting system, which, we cover in detail in Chapter 38.
Fascinating how these pieces came together over time. And Streptokinase, that first one, how did that discovery happen? You mentioned it was unexpected.
Oh, totally. It's a classic example of scientific serendipity, really.
Yeah.
Back in 1933, thanks to Tillett at Johns Hopkins, he was studying Streptococcus bacteria, and he noticed they behave differently in blood plasma versus serum.
Oh, so?
Well, in plasma, they'd clump together, but not in serum. So he suspected something in the plasma was interacting with the bacteria. And his experiments showed that when he added calcium to plasma that had the streptococci in it, a clot would form. But then, remarkably,
Could dissolve.
it dissolved right there in the test tube with the bacteria.
Uh-huh.
He realized the streptococcus were producing something which he named fibrinolysin. We now know that was streptokinase.
Amazing. A complete accident leading to a life-saving medication.
Hmm.
And chapter 43 has that timeline, right? Figure 43.1 puts it all in perspective.
Yeah, that timeline is incredibly helpful for seeing how this whole field unfolded.
Right.
It highlights Tillett's discovery of SK in 33, then plasminogen in 41, plasmin in 45, UK in 47, TPA in 57. Then you see the first clinical use of SK for heart attacks in 1955.
Yeah.
The UPET study on PE in 73, the huge GISSI trial for AMI in 86.
Yeah, and Mark trial.
Definitely. And then Alteplase gets FDA approval in 87.
And it keeps going, right, into the more recent stuff.
Oh, yeah, right up to trials like Ultima in 2014, Perfect in 2015, Attract in 2017, Optilice in 18, and Dutch Kavi in 2020. It really shows the ongoing progress of refinement in this area.
Okay, so we have these incredibly potent drugs. How do doctors actually get them to the site of the clot, where they're needed?
Right. Well, initially, the only way was systemic thrombolysis or intravenous IVT.
So just injecting it into a vein?
Exactly, usually in your arm. And while this could work, it meant using pretty high doses to get enough drug to the clot.
Okay.
And unfortunately, that increased the risk of bleeding, throughout the body.
That makes sense. You're flooding the whole system with this powerful agent. So you needed a more, targeted delivery.
Precisely. This need for precision really drove the development of catheter-directed thrombolysis, or CDT.
CDT, okay.
This involves a doctor carefully guiding a very thin tube, a catheter,
Right.
through your blood vessels right up to where the clot is located.
Sneaky.
Yeah. And then the thrombolytic drug is delivered directly into the clot through that catheter.
Much better.
Allows for much lower doses, which is why it's now the preferred approach for things like acute limb ischemia, DVT, and blockages in AV grafts, AVGs, used for dialysis. And what's really beneficial about CDT is you can often combine it with other minimally invasive procedures, to fix the underlying problem that caused the clot in the first place.
Okay, walk us through the CDT procedure itself. What does that actually involve for the patient?
Sure. So the process usually starts with the doctor making a small puncture, often in an artery or vein in the groin area. Then a very thin wire, called a guide wire, is carefully threaded through the blood vessel, navigating past the blockage. Once that guide wire is across the thrombus, a specialized catheter one with tiny holes along its side is advanced over the wire. And you want those holes positioned ideally right within the clot itself.
Makes sense.
To kickstart the process, often a concentrated burst of the drug called a bolus is delivered using a technique called pulse spray.
Pulse spray, okay.
And that's followed by a continuous, slower infusion of the thrombolytic agent through those side holes in the catheter, usually over several hours, maybe even a day or two.
And I saw heparin mentioned in there as well. What's heparin doing during CDT?
Ah, yes, heparin. It's a crucial partner. It's a blood thinner, an anticoagulant.
Right.
And it's typically infused through the sheath that's the slightly larger tube placed in the vessel to let the catheter pass through.
Okay.
Heparin's main job is basically to prevent the blood around the catheter from forming new clots while the thrombolytic is working on the existing one.
So stop things from getting worse while you fix the main problem.
Exactly. So initially, before starting CDT, the patient usually gets a full dose of heparin to get their clotting time to a specific level. We measure that with a test called APT.
APT, okay.
Stands for Activated Partial Thromboplastin Time, common blood test.
Right.
Once the CDT infusion actually begins, the heparin dose is usually reduced. And interestingly, studies have shown that giving really high doses of heparin during CDT doesn't seem to improve outcomes.
Oh.
And might actually increase the risk of bleeding. So it's really about finding that right balance.
A careful balancing act then. Prevent more clots, but don't cause bleeding. Now, CDT isn't the only tool, is it? What about combining it with mechanical thrombectomy? Sounds more aggressive.
Yeah, that's been a really significant advancement. You can make CDT even more effective sometimes by first using mechanical thrombectomy techniques.
Okay, what are those?
These are also catheter-based methods, but they physically break up or remove the clot.
Ah, like busted it up.
Exactly. Think of it like creating channels within the blockage. This allows the thrombolytic drug to penetrate deeper and hopefully work faster.
Right, get inside better.
Precisely. And this combination can potentially reduce the total amount of drug needed and shorten the overall treatment time.
Which is good for the patient.
Exactly. And while it was initially used mostly for blocked AV grafts, its use has really expanded to other arteries and veins throughout the body. Chapters 104, 161, 162 in Rutherford's go into much more detail on those specific applications.
Okay. It sounds like a sort of 1-2 punch against the clot. What are some of these mechanical methods? It sounds pretty high-tech.
Oh, there's a really interesting range of technologies out there now.
Yeah.
Some use hydrodynamic force, basically creating a vacuum effect like the Venturi effect to suck the clot out.
Wow.
Others use rotational recirculation. They have tiny rotating blades or propellers inside the catheter to chew up the clot into smaller pieces. Then there are mixing devices. They might use inflatable balloons on the catheter to kind of trap the thrombolytic drug against the clot while a rotating wire whips through it.
Clever.
Ultrasound devices deliver high-frequency sound waves, basically vibrating the clot to loosen up the fibrin strands holding it together. Simple aspiration just involves using a larger suction catheter to try and pull the clot out.
Okay.
And then there's even research into magnetic targeting.
Magnetic, really?
Yeah, where you could potentially attach magnetic particles carrying the drug and then use an external magnet to guide them right to the clot.
That sounds like science fiction.
Yeah.
And then there was something about biological targeting using red blood cells. That's new to me.
Yeah, that's a really innovative area of research. The basic idea is to essentially hitch a ride for the thrombolytic drug on red blood cells, RBCs.
Why RBCs?
Well, because they're so abundant in the bloodstream, they're relatively large, and they naturally interact with fibrin in newly formed clots. So they could potentially act as a very targeted delivery system, get the drug right where it needs to go.
Hasn't been tested.
Yeah, animal studies by a researcher named Murciano have shown that TPA attached to RBCs was more selective at dissolving fresh clots compared to just free-floating TPA.
Interesting. So what are the potential upsides and downsides?
Well, the potential benefits are getting a higher concentration of the drug right at the clot and maybe keeping it in circulation longer.
Okay.
But the current limitation seems to be that this approach might not be as effective on older, more established clots, and that prolonged circulation could also have drawbacks.
Right.
So for now, RBC targeting seems more like a promising future direction, maybe more for preventing clots than for treating existing ones right now.
It's incredible the different angles researchers are exploring. Now, once you give these powerful drugs, how do you actually know if they're working? How do you monitor progress?
That's a critical question, yeah. And unfortunately, there isn't like one simple direct blood test that tells us exactly how much of the clot has dissolved.
Oh, really?
Yeah. I mean, levels of things like D-dimer and fibrin degradation products in the blood, they do tend to rise when a clot is breaking down.
Okay.
But their levels don't really reliably tell us the extent of the thrombolysis.
So you have to rely on more indirect signs and indicators then?
Precisely. Thrombolytic therapy puts the body in a very dynamic state. You're actively trying to dissolve the clot.
Right.
But at the same time, the body's natural clotting mechanisms might still be churning away. And this whole process can lead to the consumption of important clotting factors, including fibrinogen.
Fibrinogen, okay.
If that fibrinogen level drops too low, say below 100 milligrams per deciliter, or if that clotting time test, the APTT, goes way up, like above 100 seconds, that signals an increased risk of bleeding.
So you have to react.
Yeah, in those situations, we might need to reduce the dose of the thrombolytic infusion or maybe even stop it temporarily.
What other clues do doctors look for to see if it's working as intended?
Well, we also closely monitor things like the patient's hemoglobin levels, checking for blood loss, their platelet count, and their kidney function measured by creatinine levels. These are all indirect signs of potential bleeding.
Okay.
And because of these risks, patients undergoing thrombolysis are typically monitored very, very closely, usually in an intensive care unit or a similar high monitoring setting,
Right.
with frequent blood tests like every 4 to 6 hours and hourly physical assessments. Check pulses, check for bleeding, that sort of thing.
And with catheter-directed thrombolysis, you can actually see what's happening inside, right?
Yes, exactly. With CDT, we perform serial angiography.
Angiography.
Yeah, that involves injecting contrast dye through the catheter and taking X-ray images at regular intervals, usually every 6 to 12 hours over the first day or two.
So you get pictures of the blockage shrinking.
Exactly. It lets us directly see how much of the clot has dissolved and how blood flow is being restored through that treated vessel.
That's helpful.
Very. And clinically, we're also looking for things like the return of a palpable pulse in the affected limb, improvement in the Doppler contrasound signals that measure blood flow,
Mm-hmm.
and most importantly, an improvement in the patient's symptoms. Are they feeling better? Is the pain decreasing?
Right.
Once we see that adequate blood flow to the organ or limb has been reestablished, the CDT is stopped.
And then what?
Then the patient is transitioned to full anticoagulation, usually with heparin again, to prevent that clot from just reforming.
Okay. And is there a time limit?
Yeah, it's also important to know that generally continuing thrombolysis beyond about 48 hours doesn't provide much extra benefit,
Right.
and it actually increases the risk of complications, so there's a point of diminishing returns.
So it's a very carefully managed process, constant evaluation. Yeah. Now, with such potent drugs, there are bound to be risks. What are the main complications we need to be aware of?
Yeah, absolutely. We can generally group these complications into 4 main buckets. Hemorrhagic complications, that's bleeding. Antigenicity-related complications, immune reactions. Catheter-related issues from the procedure itself. And embolic complications, where pieces of the clot break off.
Okay, let's start with the big one, bleeding.
Hemorrhage is definitely the most concerning risk, always. We differentiate between major bleeding,
Like what?
like bleeding inside the brain, which is obviously very serious, or bleeding in the space behind the abdominal organs, the retroperitoneum, or significant bleeding in the GI tract. And then there's minor bleeding, which is typically localized just to the site where the catheter was inserted, the puncture site.
But even minor bleeding can become major. Right.
Exactly. If a large collection of blood, a hematoma, forms, or if blood tracks into deeper tissues, it can escalate. Using ultrasound guidance when we're putting the catheter in can help minimize that puncture site bleeding.
And what about bleeding elsewhere in the body, remote sites?
Yeah, the risk of bleeding at sites away from the catheter tends to increase with higher doses of the thrombolytic drug and with longer infusion times.
Makes sense.
It's because the more drug you use and the longer it's circulating, the more it can interfere with the body's overall clotting ability.
So some treatments are riskier than others?
Generally, yes. Patients being treated for conditions that often need higher doses and longer infusions, like acute limb ischemia, PE, DVT, they generally face a higher risk of remote site bleeding compared to those treated for heart attacks, strokes, or blocked AV grafts or catheters, where lower doses are often sufficient.
And the most feared bleeding complication is, of course, bleeding in the brain intracranial hemorrhage, ICH.
Absolutely. ICH is the most dreaded complication, and unfortunately, it has the highest incidence in patients getting thrombolytics for acute ischemic stroke.
Why stroke specifically?
Well, the thinking is that the thrombolysis not only restores blood flow to the oxygen-starved brain tissue, but it might also dissolve tiny clots in areas that have already been damaged by the stroke, potentially leading to bleeding when the blood flow returns. It's called hemorrhagic reperfusion.
Okay. What are the rates like?
For stroke, rates range from about 6.4% to 8.8%. The risk of ICH and other conditions is lower, but it's still a significant concern. For PE, it's somewhere between 0% and 4.5%. For heart attacks, 0.3% to 1.8%. For peripheral artery occlusion, around 1% to 2%.
And overall major bleeding rates?
They can be quite significant depending on the situation. For acute limb ischemia, reported rates are 10% to 27%, PE 5% to 21%, AMI 0.3% to 5.9%, and DVT 4% to 11%.
Those are definitely numbers that highlight the seriousness.
Yeah.
Okay, what about those antigenicity-related complications you mentioned? Immune reactions.
Right. These are primarily a concern with Streptokinase, SK.
It comes from bacteria.
Exactly. It's derived from bacteria, so the body's immune system can recognize it as foreign and mount a response.
What kind of response?
Minor allergic reactions like a rash or fever occur in about 1% to 10% of patients. Thankfully, severe, life-threatening allergic reactions are very rare, less than 0.01%.
Can you do anything to prevent that?
Yeah, we often give patients medications like methylprednisolone, antihistamines, or acetaminophen before giving streptokinase to help reduce the risk.
And the other drugs, urokinase, alteplase.
In contrast, urokinase and alteplase are proteins that are naturally present, or very similar to proteins naturally present in the human body. So allergic reactions to those are extremely rare.
Okay, and then there are complications directly linked to the catheter itself during CDT.
Yes. Anytime you're navigating instruments through blood vessels, there are inherent risks.
Like what?
With CDT, these can include dissection, where the catheter tip might create a small tear in the artery wall.
Ouch.
Formation of a pseudoaneurysm, which is like a contained leak of blood outside the artery. dislodging pieces of the thrombus as you move wires and catheters around,
Hmm.
and, of course, bleeding around the introducer sheath, that larger tube initially placed in the vessel.
Right. Lastly, you mentioned embolic complications. What happens there?
So as the blood clot is being dissolved, small fragments can sometimes break off and travel downstream in the bloodstream.
Uh-oh.
Yeah, potentially causing a new blockage somewhere else. This is most commonly seen when treating acute limb ischemia.
How would you know?
Well, a patient might initially show improvement, pulse comes back, Doppler signal gets better, but then suddenly their symptoms worsen because a new embolus has lodged further down the leg.
How often does that happen?
In clinical trials for limb ischemia, these embolic events occurred in about 9% to 13% of patients.
And you fix it.
Fortunately, yes, in many cases. Advancing the catheter further down the vessel and continuing the infusion can often dissolve these new clots.
Is it common in other treatments?
It's less frequent in other applications, although it can happen in a small percentage of PE patients after DVT treatment, and it's a rare but possible risk when treating blocked catheters or AV grafts.
So it really is a constant balancing act. Benefits versus risks.
Which brings us to the crucial question. Who should not get these treatments? What are the contraindications?
Right. We categorize these into absolute contraindications.
Meaning definitely no.
Definitely no. The risk clearly outweighs any potential benefit. And relative contraindications.
Meaning maybe, but be careful. Exactly. Thrombolysis might still be considered, but only with extreme caution and a very careful evaluation of risks versus benefits.
Okay, what are the absolute ones?
Active internal bleeding, obviously. A recent stroke, significant trauma or surgery on the brain or spinal cord within the past 2 months. A known tumor in the brain. Severe, uncontrolled high blood pressure. Any uncontrollable blood clotting disorder, and of course a history of a severe allergic reaction to the specific drug you're considering.
Makes sense. And the relative contraindications, where you have to weigh things up.
That list includes major surgery or obstetric procedures within the last 10 days, a recent biopsy or other invasive procedure in a spot where bleeding would be hard to control, recent bleeding in the stomach or intestines, recent significant trauma, including CPR, the presence of a blood clot in the left side of the heart, an infection of the heart valves called subacute bacterial endocarditis, severe liver or kidney disease, bleeding in the back of the eye due to diabetes, diabetic hemorrhagic retinopathy, acute pancreatitis, pregnancy, and really any other condition where bleeding would pose a significant hazard or be very difficult to manage because of where it is in the body. It's a long list, highlighting just how many factors a doctor has to carefully consider.
It really emphasizes the complexity. Okay, let's delve more into the agents themselves. You mentioned they could be broadly classified.
Yes. The main split is between plasminogen activators, which work indirectly, and direct-acting agents.
Explain the indirect ones first.
Yeah.
Plasminogen activators.
Right. They're like a key that unlocks the body's own clot-busting system. They convert that inactive protein, plasminogen, into its active form, plasmin.
And plasmin does the work.
Plasmin then goes and breaks down fibrin, the main structure of the clot.
Okay.
And these activators can be further divided. There are the ones that are biologic, naturally occurring, or from biological sources like Streptokinase and Urokinase.
Right.
And then there are the ones made using genetic engineering, the recombinant versions like Alteplase, Reteplase, and Tenecteplase.
And the direct-acting ones.
They're designed to attack the fibrin strands directly, bypassing that plasminogen activation step.
Okay, let's start with those biologic, naturally occurring activators. We've talked about Streptokinase, SK, the first one.
Correct. SK was initially FDA approved for a pretty wide range of conditions, heart attacks, PE, DVT, peripheral clots, sold as Streptase cabecinase.
But not used much now.
Right. The main U.S. manufacturers stopped making it back in 2004, largely because of those side effects we discussed, especially the antigenicity.
Right, the immune reaction.
Exactly. So it's very rarely used here. Now, you still see it in some developing countries because it's relatively inexpensive.
Can they make it recombinantly now?
They can, yeah, using E. coli bacteria.
Yeah.
But sometimes the potency can be a bit variable.
Okay. You mentioned it comes from strep bacteria. How does it actually work, like at the molecular level?
So SK is a protein, 414 amino acids long, produced by certain types of strep bacteria. It has 3 main structural parts, or domains, and it's the beta and gamma domains that are key for it to latch onto plasminogen and basically flip the switch to turn it into active plasmin.
Okay.
The complex formed by SK and plasminogen doesn't last long in the bloodstream, maybe 20 minutes.
Right.
And while there are natural inhibitors in the blood that try to shut it down, the therapeutic doses we use are usually high enough to overwhelm those inhibitors and get the job done.
But the big challenge, as we said, is that immune response potential.
Exactly. Because it's a foreign protein, your body can develop antibodies against it if you've had a strep infection before or if you've received SK before.
And those antibodies cause problems.
They can inactivate any later doses of SK. And these antibodies can stick around for a while, anywhere from a few days to maybe even 4 years.
Wow.
So, while minor allergic reactions on repeat exposure aren't super common, maybe 4.4%, more serious reactions like life-threatening anaphylaxis and serum sickness have been documented. So, because of this risk, we generally avoid giving SK again within 5 days to about a year after the first dose.
Makes sense. Okay, let's move to urokinase, UK. You said it's different regarding the immune response.
Yes. Unlike SK, urokinase doesn't typically cause an immune reaction.
Why not?
Because it's actually a protein that's normally found in small amounts in human plasma anyway. Its in vivo name is urine plasminogen activator, UPA.
UPA.
And it actually does other things in the body besides just busting clots involved in cell signaling, cell growth, stuff like that.
Where does it come from?
Primarily produced by cells in the kidney, and the UK that was used commercially was initially extracted from, well, human urine.
Urine? Yep.
Later from donated neonatal kidney cells grown in culture.
Are there different forms of it?
There are a few. The initial form is pro-rokinase, single-chain, low activity, needs activation by plasmin near fibrin. The main active form in urine is high molecular weight UK, a 2-chain protein. And there's also a lower molecular weight version, kind of a degraded form.
Was it a good alternative to SK?
It was valuable, yeah. It doesn't have as strong an affinity for fibrin as some others, but it was the main alternative for a long time. Marketed as abakinase originally.
Right.
It's cleared pretty quickly by the liver, short half-life.
And abakinase had that complicated history, right, with the production halt.
That's right. The abakinase brand got some stigma after the FDA stopped its production in 1999 due to manufacturing concerns, potential contamination issues.
Did that spur development of other drugs?
It definitely did. It highlighted the need for reliable alternatives. Abakinase was later reintroduced in 2002, then sold, eventually renamed Kinlytic.
And what's it approved for now?
Currently, its only FDA-approved use in the U.S. is for treating pulmonary embolism, though it was previously approved for AMI and clearing catheters, too.
Okay, so those are the naturally occurring ones. Now, the recombinant agents made in the lab, was there a recombinant urokinase?
Yes. Researchers developed recombinant versions to address the sourcing challenges, made using genetically engineered mouse cells.
Okay.
One product, urokinase alpha, was marketed as OpenCath-R for clearing blocked catheters, showed good results in trials, but it's currently not available for use in the U.S.
Okay. Then we have Alteplase, RTPA. You said that's the most common one used now?
That's correct.
Yeah.
Alteplase is essentially a lab-made copy of the natural TPA that our own endothelial cells lining our blood vessels produce.
How do they make it?
Using recombinant technology, typically with cells from Chinese hamster ovaries, believe it or not, allows large-scale production.
And it's identical to natural TPA.
Pretty much identical structure. About 70 kilodaltons, 5 distinct functional regions or domains.
What do the domains do?
Well, the protease domain is the part that actually snips plasminogen to activate it.
Okay.
The finger domain and the 2 kringle domains help it bind to fibrin in the clot. Those kringles have specific sites that really like fibrin.
Right, targeting.
Exactly. And the EGF domain helps the liver recognize and clear it, which contributes to its very short half-life, only about 5 minutes initially.
And because it's like our own TPA, no immune issues generally.
Typically lacks antigenicity, yeah. Very rare hypersensitivity reports, but generally not an issue.
And it's marketed under different names depending on the use.
Yes.
Yeah.
In the U.S., it's Activase for heart attacks, PE, and stroke. And then there's that lower dose formulation, Cathflow Activase, in 2 milligram vials, specifically for clearing central venous catheters.
Developed by who?
Genentech here in the U.S. and Boehringer Ingelheim in Germany, where it's called Actilase.
Okay. Next up, Reteplase. How's that different from Alteplase?
Reteplase is a modified RTPA. It's been engineered. They removed the finger domain, the EGF domain, and the first Kringle domain.
Why remove those?
Well, and it also lacks the sugar molecules, the carbohydrate side chains, because it's made in E. coli bacteria. These changes affect its properties.
That's so.
For example, lacking the EGF domain and those sugars reduces how quickly the liver clears it. So its half-life is significantly longer, about 15 minutes initially. Terminal half-life over an hour and a half.
And that changes how you give it.
Exactly. That longer half-life allows for more convenient dosing as 2 separate quick 5e injections, boluses, given 30 minutes apart.
Okay. How's it cleared?
Cleared by both kidneys and liver. And even though it's missing some domains, it still keeps some fibrin specificity through its remaining Kringle 2 domain.
Who developed Reteplase?
Initially, Boehringer Ingelheim, marketed as Rapamycin outside the U.S. Here, the rights have moved around a bit, currently marketed as Reteplase by Cornerstone Therapeutics.
And approved for.
FDA approved for treating acute myocardial infarction.
Okay. Finally, Tenecteplase, another modified RTPA.
Exactly. Tenecteplase is another engineered version, also made in Chinese hamster ovary cells. It has 3 specific changes in its amino acid sequence compared to natural TPA.
What changes?
2 substitutions in the Kringle 1 domain, and then a swap of 4 amino acids in the protease domain to 4 alanines.
What does that do?
That tetraalanine substitution significantly increases its specificity for fibrin in the clot, makes it more targeted.
Okay.
The other 2 changes help reduce how quickly it's cleared from the blood and are important for maintaining its clot-busting ability.
So these tweaks give it advantages over standard RTPA?
Yeah, generally. Tenecteplase has a longer half-life than RTPA, but still keeps good fibrin binding. Lab studies show it's more resistant to a natural inhibitor called PAI-1.
PAI-1.
And has significantly enhanced fibrin selectivity compared to RTPA.
What's its half-life?
Around 20 to 24 minutes initially, longer elimination phase primarily cleared by the liver.
And how is it given?
As a single IV injection, a single bolus, with the dose adjusted based on the patient's weight.
Okay. Approved for?
FDA approved for AMI back in 2000, sold as Tenecteplase in the U.S., Metalise elsewhere.
Okay, so those are all the plasminogen activators working indirectly. What about the direct-acting agents? You mentioned plasmin itself. How does that work differently?
Right. All the ones we just discussed work by activating plasminogen, which then becomes plasmin to break down the clot. Direct-acting agents, like plasmin itself, theoretically offer an advantage. They directly attack the fibrin strands.
Skipping a step.
Exactly. Could potentially lead to a more consistent, predictable response because you don't rely on the patient having enough plasminogen.
Sounds good. What's the catch?
The major challenge is that these direct agents are rapidly inactivated by natural inhibitors circulating in the bloodstream, like alpha-2 antiplasmin.
Ah, so you can't just inject them.
Right. Can't give them systemically like the activators. They need to be delivered directly to the clot using a catheter. CDT is essential.
And how far along is the research on plasmin as a direct agent?
Well, plasmin was actually looked at way back in the 60s, but initial results weren't great because of that rapid inactivation. But later animal studies showed that direct catheter delivery could break down clots faster and more effectively than activators.
So it's being revisited?
Yes. A company called Telecris, now part of Grifols, has been investigating 2 forms. One is a genetically engineered, shorter version called gamma plasmin, designed for potentially increased activity and fibrin targeting.
Okay.
The other is human plasmin obtained from carefully screened blood donors.
Have there been human trials?
Yes, early phase trials have shown some promising results with CDT delivery of human plasmin for acute clots in leg arteries and even in stroke.
But still figuring things out.
Yeah, the optimal delivery method, the best infusion rates that's still being studied, but it's definitely an active area.
Interesting. Sounds like the future might involve more of these direct agents with targeted delivery. Okay, we've covered the different drug types. Let's circle back to how they're actually used in specific situations. You mentioned doctors sometimes use them off-label.
That's a really important point, yeah. While the FDA approvals provide clear guidelines, experienced doctors will often consider using these drugs off-label if they believe it's the best option for that patient, based on the evidence and their own clinical judgment.
And the choice of drug depends on?
Often comes down to the specific situation, the doctor's familiarity with the agents, and honestly, what's readily available at their hospital. Alteplase is generally the most widely available, then maybe Reteplase or Tenecteplase.
Okay, let's start with acute myocardial infarction heart attacks. How have thrombolytics changed things there?
Well, in most modern centers with the capability, emergency cardiac catheterization going in with a balloon or stent to open the artery.
Angioplasty, PCI.
Right, PCI. That's largely become the preferred first treatment for AMI.
Okay.
However, in hospitals that don't have immediate access to a cath lab, intravenous thrombolysis still plays a critical life-saving role, especially if given early.
So time is key.
Absolutely. And in fact, the development and dosing of many newer thrombolytics were initially tested and refined specifically in AMI patients.
Right, like those big trials.
Exactly. The very first major trial showing the benefit of 5E thrombolysis for AMI was Jesse back in '86. Showed streptokinase significantly reduced mortality. ISIS-2 confirmed that, and also showed adding aspirin was even better.
And not up to you.
Extensively studied. ASSET showed it was better than placebo, and comparisons between RTPA and SK generally showed RTPA was better at restoring coronary flow quickly and reducing 30-day mortality risk.
Okay.
And as we said, Reteplase and Tenecteplase also went through rigorous trials leading to their AMI approval.
Got it. What about pulmonary embolism, PE, clots in the lungs? How are thrombolytics used there?
Yeah, multiple trials have looked at various agents and doses for PE. Interestingly, unlike AMI, IV thrombolysis for PE hasn't consistently shown a clear mortality benefit across all patient groups.
Oh, so how do they measure success?
Often by improvements seen on imaging, pulmonary angiography, lung scans, or by a reduction in the pressure within the pulmonary arteries.
What drugs are used?
Currently, Alteplase is common, sometimes urokinase depending on availability and indication.
And what do the guidelines say?
The 2016 ACCP guidelines suggest routine IV thrombolysis is not recommended for most acute PE patients.
Okay, so when is it recommended?
It is recommended for those who are hemodynamically unstable, basically in shock, very low blood pressure.
The really sick ones.
Exactly. Or for patients whose condition is rapidly getting worse despite getting anticoagulation.
And how should it be given, IV or CDT?
When IVT is used, shorter infusions are generally preferred over CDT. The guidelines offer a weak recommendation for considering CDT, especially combined with mechanical thrombectomy, in patients with severe PE who are hypotensive and either can't get IVT, failed IVT, or are likely to die before IVT could work.
That seems like a subtle shift considering CDT more now. What's driving that?
It reflects growing evidence that using mechanical devices with CDT can be more effective at removing the clot, potentially allowing for lower drug doses.
Like that ecosystem you mentioned.
Exactly. The ecosonic endovascular system, ECOS, it combines ultrasound waves with drug delivery via catheter.
And the ultrasound helps.
Helps loosen the clot structure, allows the drug to penetrate better. The Ultima trial was key, showed ECOS-assisted CDT was better than just anticoagulation at reversing right heart strain and intermediate risk PE. Led to FDA approval in 2014.
And other trials supported it.
Yeah, subsequent trials like Seattle 2, meta-analyses, they further supported ECOS's safety and effectiveness in improving heart function, lowering pulmonary pressures, reducing clot size, all with relatively low bleeding rates.
Okay.
The PERFECT trial also supported CDT for severe PE, and OPTIL-ICP showed even lower doses and shorter infusions with ECOS could still improve RV function and reduce clot burden in submassive PE.
So ongoing research in this area.
Definitely. Trials are still evaluating ultrasound-assisted CDT compared to standard CDT and looking at low-dose regimens versus just heparin.
Okay, let's switch gears to acute ischemic stroke.
Right.
Rapid intervention is absolutely critical there. What's the role for thrombolytics?
Absolutely critical. Well-controlled trials have firmly established the major benefits of 5E thrombolysis in stroke, but the key is the time window. Current guidelines recommend giving it within 3 hours of symptom onset. Some evidence supports extending that to 4.5 hours in carefully selected patients. RTPA, Alteplase, is currently the only FDA-approved thrombolytic for acute ischemic stroke in the U.S. Others have been studied, but RTPA is the standard.
What about Tenecteplase? You mentioned a trial.
Right. One phase 2 trial suggested maybe no difference between Alteplase and Tenecteplase, but a more recent phase 2, Extend-IA-TNK, showed Tenecteplase led to higher rates of vessel reopening and better functional outcomes compared to Alteplase when given before mechanical thrombectomy within that 4.5-hour window.
So might Tenecteplase become an option?
The 2019 ACA acid guidelines suggest Tenecteplase might be a reasonable alternative to Alteplase in patients also eligible for mechanical thrombectomy, but standard dose Alteplase is still the primary recommendation.
What about combining 4 with CDT or mechanical removal?
Trials like IMNS-2 and IMS the synthesis expansion, they didn't show a clear benefit of adding CDT to add to DPA. However, some observational studies and meta-analyses suggest that for patients with blockages in the large brain arteries, using mechanical thrombectomy sometimes with added CDT or IVT can lead to better outcomes than IV RTP alone.
So what do the current stroke guidelines recommend overall?
They strongly recommend giving IV Alteplase even if you're considering mechanical thrombectomy. And they strongly recommend mechanical thrombectomy itself in eligible patients who meet specific criteria: good function before stroke, major artery blocked, over 18, specific stroke score, and treatment started within 6 hours.
Okay, complex but crucial. Now, acute limb ischemia, sudden blockage threatening an arm or leg.
Yeah. The initial evidence for thrombolysis here came from case series, suggesting it could open arteries, maybe avoid surgery. Early studies hinted CDT might be safer and more effective than IVT.
And then came the bigger trials.
Yes, 3 key randomized trials provided more definitive evidence for CDT benefit, specifically in ischemia present for less than 14 days.
Which trials?
The Rochester trial, CDT with urokinase versus open surgery for 7-day ischemia, found similar limb salvage at 12 months, but actually better overall survival with CDT.
Interesting.
The Style trial, surgery versus CDT, RTPA or UK, for up to 6-month ischemia, stopped early due to overall worse CDT outcomes, but a subgroup analysis of those with 14-day ischemia showed lower amputation rates at 6 months with CDT.
Okay.
And the 2PS trial, surgery versus CDT UK for 14-day artery or bypassed graft blockages, found similar amputation-free survival and mortality at 12 months. CDT let about 40% avoid surgery, but it did increase major bleeding risk.
So what's the takeaway for limb ischemia?
Current recommendations generally support CDT for less severe ischemia. Rutherford class I30 present less than 14 days. Might be useful in select IAB cases too.
But some reservations?
Yeah, enthusiasm is a bit tempered by the time it can take for current drugs to work. Modern CDT often uses lower doses infused over longer periods.
Is faster better?
Studies suggest higher dose, faster infusions might open the vessel quicker initially, but don't necessarily lead to better long-term outcomes or limb salvage, and they increase bleeding risk.
What about ECOS or mechanical approaches here?
Growing interest in ECOS-assisted CDT, maybe allowing lower doses with similar effect, potentially safer like the DUET trial showed. Pharmacomechanical thrombectomy, PMT, is also used. Success rates similar to CDT alone, but many patients still need extra procedures afterwards.
So still evolving.
Definitely. Things like contrast-enhanced ultrasound to speed up low-dose CDT, aspiration mechanical thrombectomy, they show promise but need more clinical data comparing them to standard CDT.
Okay. Deep vein thrombosis, DVT, another big area. What's the evidence for thrombolytics here?
Yeah, initial data came from smaller trials and registries. An early analysis in '84 suggested SK opened veins better than heparin but caused more bleeding.
What did later reviews find?
A 2005 review looked at 18 IVT trials for DVT. Most compared SK to heparin. Overall conclusion: IVT improved vein patency but increased bleeding risk. A later Cochrane review confirmed IVT was linked to lower risk of post-thrombotic syndrome, PTS, and leg ulcers long-term, but still higher bleeding risk than just anticoagulation.
What about CDT for DVT?
A registry study showed higher patency with CDT versus anticoagulation, but also an 11% major bleeding rate with CDT. Before 2012, very little randomized data comparing CDT directly to anticoagulation.
But then came Kevin.
Right. The landmark 2012 CAVINT study randomized 209 patients with acute ilofemoral DVT upper leg to CDT or anticoagulation.
And the results?
Significantly higher rates of the vein being open at 6 months and lower PTS rates at 24 months in the CDT group, but 20 bleeding complications in the CDT group, 3 major.
So a trade-off again. What about ECOS for DVT?
A single-center study by Engelberger showed high patency and low PTS bleeding with ECOS-assisted CDT. But a later randomized trial found no significant difference in long-term outcomes between ECOS CDT and standard CDT alone.
So the debate continues. Does opening the vein quickly matter long-term?
That's the core question. Current guidelines generally favor anticoagulation as primary treatment for most DVTs.
But CDT is an option for some.
Yes, the ACCP guidelines say CDT or IVT can be considered for select patients who really prioritize preventing PTS and are less worried about the initial complexity, cost, and bleeding risk.
Who are those patients typically?
Usually symptoms 14 days, iliofemoral DVT, good functional status, low bleeding risk, life expectancy 1 year.
What about recent big trials like Tragedy?
A tragedy compared PMT plus anticoagulation versus anticoagulation alone. Found no significant difference in overall PTS risk, but did show a reduction in moderate to severe PTS in the PMT group, but again, increased major bleeding.
And DUTCH cavia?
Compared eco-CDT versus anticoagulation. Found no difference in PTS at 1 year, but a higher major bleeding rate with ecos. So the picture is still complex.
Okay, let's talk about blocked arteriovenous accesses, AV fistulas, and grafts in dialysis patients. Are thrombolytics used there?
Yes, definitely. Use reported since the early 80s. Various techniques developed to clear these clotted accesses, which are a common headache for dialysis patients.
Are any drugs specifically approved for this?
No, actually, no thrombolytics are specifically FDA approved for AVG occlusion, but there are tons of case reports and retrospective series using pretty much every agent available.
What do the studies show?
A recent study showed high technical and clinical success using urokinase and Alteplase. Patency was better in fistulas than grafts. Recurrent clotting within 90 days was a bad sign for long-term patency.
What about mechanical methods?
Ultrasound-guided PMT has been described with successful patency rates, but reclotting can still be a significant issue.
Are low doses used?
Yes, successful use with minimal bleeding reported for low doses of RTPA 2 mg, Tenecteplase 1 mg, Reteplase 1U.
Okay. And finally, blocked central venous catheters, the lines for giving meds.
Right, RTPA, specifically cathephyloactivase 2 mg vials, is FDA approved for this.
Based on what evidence?
The COOL trial, over 1,000 patients, showed 1 dose of RTPA significantly increased catheter patency compared to placebo. Worked similarly across different catheter types, rare adverse events.
Is it cost-effective?
Using thrombolytics to restore patency is generally cheaper than replacing the catheter, but it doesn't seem to impact length of hospital stay or readmission rates. Newer agents might offer similar results, maybe faster.
Saving kids.
Yes, RTPA found safe and effective in children, too.
What about dialysis catheters?
They were excluded from the CAFLA trial, so not technically in the FDA indication, but successful use of RTPA 2 mg, Reteplase, Tenecteplase 2 mg has been reported. Trials showed Tenecteplase improved flow in dysfunctional dialysis catheters.
Wow, incredibly versatile drugs. The chapter even mentions some miscellaneous uses, like during surgery.
Yeah, briefly. Intraoperative thrombolysis can be a useful add-on to open surgical thrombectomy.
How?
Delivering the drug directly into smaller distal vessels during surgery can help break down clots the surgeon can't physically reach. And for really extensive clotting in tiny limb vessels, a technique called isolated limb perfusion with high-dose thrombolysis has been described.
What's that involve?
Temporarily isolating the limb's blood supply, circulating a high concentration of the drug through it, maybe using a pump, maximizes drug delivery locally, minimizes systemic effects, maybe reduces reperfusion injury.
Is combining surgery and thrombolysis common?
Not frequent, no. But it can be limb or even life-saving in select complex cases. A recent study on clotted popliteal aneurysms showed promise with intraop thrombolysis, but larger trials are needed.
This has been incredibly comprehensive, really covers the landscape. The chapter even has that algorithm, right? Page 562, summarizing treatment approaches.
Yeah, that algorithm is a really practical tool for clinicians. It gives a visual guide to the decision-making for stroke, MI, limb ischemia, PE, DVT, takes into account timing, severity, facility resources, patient factors. Very useful.
And of course, for anyone wanting to dig even deeper, the chapter lists those key references, the pivotal studies that really shape the field.
Absolutely. Landmark studies like GISI for heart attacks, the chest guidelines, the original description of urokinase, Rochester and Style for limb ischemia, Gusto comparing agents in AMI, 90s for stroke, Topaz showing reduced need for surgery, the early UPET trial for PE, and Tillett and Garner's original SK Discovery article. These are all foundational papers, absolutely crucial.
Okay, let's try and bring it all together for our listeners.
Yeah.
What's the key takeaway from this deep dive into thrombolytic agents?
I think the most important thing to remember is that these agents have fundamentally transformed how we treat thromboembolic diseases. They offer a less invasive alternative to open surgery in so many critical situations. The key insight for you is realizing we've moved from, a very blunt instrument like surgery to incredibly sophisticated, targeted therapies that can literally dissolve problems from within. But, and this is crucial, that power comes with the need for equally sophisticated understanding and careful monitoring.
And it's a field that's clearly still evolving, constantly pushing forward.
Precisely. We're continually seeing advancements, both in the drugs themselves aiming for more targeted, more effective, safer options, and in the techniques used to deliver them, like the evolution of CDT and these increasingly smart mechanical thrombectomy devices.
So for anyone facing one of these events, it's reassuring to know these advanced treatments exist.
Absolutely. And understanding the different types of thrombolytics, how they work, their specific uses, the potential risks, that's crucial for clinicians and also helpful for patients facing these conditions to understand their options.
And all this progress is built on solid science, right?
Yeah.
Rigorous research and clinical trials.
Exactly. The effectiveness and safety of these therapies across all these different vascular conditions have been and continue to be rigorously evaluated through countless crucial clinical trials. That's how we refine our understanding and improve patient care.
This has been a truly illuminating discussion. It really makes you think, doesn't it? Considering this continuous progress in thrombolytics and endovascular techniques, how much further might vascular medicine shift away from traditional open surgery for clots? What entirely new challenges or maybe exciting opportunities might pop up as these incredibly targeted treatments keep evolving and getting even more refined? It's definitely something profound to consider.